So I'm delighted to be here, and I feel like this talk is easier coming in the afternoon because there's so much groundwork that I often have to lay that so many people did such a great job in. So this is fun to be here, and easier than Steve's talk because I'm just going to talk about one study. How am I moving this forward? Sorry. Oh, right. Yeah, there we go. Okay. Oops. Okay, well, the slide before that, I don't even need to go back to it, is just to say, where am I going with this? So I'm going to say just a few words about context, mainly spend time on this this pragmatic trial that we're in the midst of implementing, and then really try to focus on some of even though we're midway through, some of the lessons learned and some of the barriers and maybe some take-homes if others are doing something similar. Also, there's a little bit more about sort of research methods that are built into this, and I think some of it's relevant for some of the evaluation that many have talked about. So I'll spend a little bit of time on that. So this first slide is something that I think at least these separate trajectories, I think many people in the room are familiar with, and many of you were involved in these studies. This was and this is adapted from some of the work that Rick Deo has done, and opioids are not up here, but I think what's important to look at here is sort of the context for how are we treating care in our systems. And if you can read some of those things, I know that the print is small, but it's looking at the increases in kinds of treatment for chronic pain and how that's proceeded since 1993 until currently. And you can see a tremendous increase in surgery, spinal fusions, 660%. You can see that the injections, epidural and steroid injections, 250% increase in imaging, that's over 300%. When you look at medical expenditures in that same MEPS report, they also looked at the self-reported functioning, and you see the expenditures going up, self-reported functioning going down, and the only line that's going down there at quite a clip is the availability of multidisciplinary pain treatment centers. So what we really have here is something where I would argue you're using sort of acute kinds of tools to treat a chronic pain process. And also that a lot of the things that we're all struggling with are not that we don't know how to do CBT or other kinds of treatments, but how do we do these in the kind of systems that we're living in? This is adapted from something that Matt Gallagher presented a while back, and I don't need to belabor this because we've been talking about this all day, but just really the bind that primary care providers find themselves in, both in terms of the immediate practice environment, which is a lot of these factors on the right-hand side, and then some of the national, kinds of demands, and how this has really been such a pendulum swing from the early 2000s to where we are today with the opioid prescribing. The trial that I'm going to talk about is primary care based, but I think one of the things that we've been really grappling with is there's really many reasons that this kind of treatment should be in primary care settings. But there are a lot of structural and process and other kinds of factors that make that really difficult. And a lot of our systems are right now better aligned to provide this in tertiary care settings. So again, I think some of the things we really need to focus on are some of those systems level kinds of issues. The last sort of contextual thing that I'll say something about briefly is what does it mean to be doing this in Kaiser Permanente? Because I think a lot of times when I talk about this study on the national level, people say, well, you're in Kaiser, that's simple, it's integrated, you can do all this work. I think that even though we do have an integrated delivery system, Kaiser is both the provider for the care in the insurance, but that there are a lot of things that are different across the different Kaisers. They're really semi-autonomous regions. They have very different structures in terms of what's internalized and some of the services that are still external. But there are these kinds of features that make this kind of collaborative care. I think if we can't do it in Kaiser, it's hard to do it anywhere, and we're learning a lot even there about the barriers. So the pragmatic trial that I'm going to talk about was really something that I didn't design, but it was the primary care and a lot of the specialty care leadership within the Northwest region of Kaiser and our operational leaders coming to me initially because they were going to do a small pilot. They said, we really need to deal with our worst of the worst patients, the people that belong to everybody and nobody. Their primary questions were, how do we keep our primary care providers from burning out and leaving the healthcare system? And what do we do with patients with complex pain who belong to everyone and no one? And they actually had come to me and they had a list of the 100 worst patients in the system. And they said, see, these are the ones, look at what they're doing. And what these patients were doing is they were boomeranging all over on the left-hand side there. And that probably looks familiar to everybody in here. And what we wanted to do was really standing on the shoulders of what, many people in this room have done. Aaron, Steve Dobsha, Michael Von Korf, the folks in Indianapolis have done a lot of this sort of core work that we were building on. What we were doing is we were doing it in the context of we're doing it in the context of a large-scale pragmatic trial. And I would say that many people here have been doing this kind of work for a long time, and I think it's been somewhat rebranded and is sort of like newly sexy again. But the nice thing is that NIH and others are really taken with this, and I think are supporting a lot of this work and really bringing people together and looking at what does it take to do this kind of systems level work. So this is kind of small to read, but essentially just a few of, what are you trying to do in pragmatic trials? Well, you're targeting the population with greatest needs. So, as few exclusion factors as possible. You're tailoring it to what's practical and sustainable. The idea here is that you're not doing it in a parallel research universe, but it's really deeply embedded in the delivery system, and that the questions that you're coming to the table with are those that are at highest priority to the clinicians, policymakers, and patients, and that you're frequently relying on the data from the EHR. You're looking at things like return on investment and health service use, and that you can do this on a very large scale. Oh, this looks so tiny, but let me just say what this is. So this is part of the NIH Collaboratory, which is a group of 9 studies that are across a whole lot of domains. Doug Zatzik has one he didn't talk about today, but is thankfully more complex than mine, I always say. These are being done across the country. This is actually a really nice resource. They're kind of small, but there are a lot of tools on that website. Duke is the coordinating center, and they've done a nice job pulling that together. When you're doing pragmatic trials, there's something called the Pre-C and now the Pre-C 2, which is really kind of the way you think about how pragmatic are what you're doing. And so these are different dimensions that allow you to really gauge that. Everything from how are you recruiting people? Are you working in settings where really these problems are where they need to be addressed? How flexible is the delivery of the intervention? Adherence to is primary outcome really what you need to be looking at if you're a frontline provider or administrator. And if you're very pragmatic, you're way out on the edges. If you're doing an efficacy trial, you're sort of right in the middle. This was a recently published paper where several of us that had some of the original collaboratory trials, they judged based on our protocols how pragmatic we were. And as you'll notice, PPACT, which is our trial, is not real far out on the edges. And I would argue that these kind of complex behavioral trials really, there are things that you want to control for more. So it's a little bit different than some of the large, simple trials that are more at a structural level. So PPACT is the trial that we're doing. This is the aim is really to coordinate and integrate services that are feasible and sustainable in primary care for helping patients adopt self-management skills. So very much in line with what you were hearing earlier. The primary aim is really to improve functioning related to pain. Secondarily, we're also looking to limit opioid medications and to identify and treat exacerbating factors. This is a cluster randomized design. It's clustered at the level of the PCP. We have just recently finished the active part of the intervention, and we have 851 patients enrolled, and that represents 106 PCP clusters, 273 PCPs, and this is across 3 regions of Kaiser, so Hawaii, Georgia, and the Pacific Northwest. Importantly, I'd noted earlier that the clinicians, when they came to us, said, we really need help with the worst of the worst. So who we're trying to target on in this trial is they have to be on chronic opioid treatment. And then in addition to that, we're really looking at folks that are high utilizers. So we're prioritizing those people that have 12 or more visits to primary care in a 3-month period, that are on simultaneous benzos or are over 120 morphine equivalents in their opioids. The intervention is this kind of collaborative care intervention that we've been talking about. And I'll go to the next slide and show you a little bit more about that. The outcomes are very simple, and this was by design. We're using the PEG. I will say the PEGs because we're using the sleep item too. Erin's initial paper had the 3 or the 4 item in there. That's our primary outcome, but we're also looking at opioids, and we're looking at pain-related health services and cost. This is a schematic really showing the intervention, but it's very small. So let me just talk through a couple of components to that. We bring patients in. We do an intake that's really based on legacy instruments that are already embedded into our care system. It's a core group component where there's 12 in-person groups. There's health coaching by telephone. And the part in the blue there on the side is what we're doing with the PCPs. This is really meant to support them within the primary care environment, so really using the tools in the patient-centered medical home. So a lot of this is in support of them rather than them having to do this directly. But we do have some components we ask them to do. We ask early in the intervention that the PCPs reach out with a telephone call to the patients and really reinforce the fact that they're involved in this and that they're doing the self-care management. Frank Keefe, who is a close co-investigator on this, I think really emphasizes so much of the dynamic in the primary care office is people coming in at the top of a pain flare, and that's the conversation. So to really shift the dynamic with that by having this kind of outreach. This is our incredibly complex sort of conceptual model. But when we started this, and I'd mentioned that that they really wanted us to focus on these very complex comorbid patients. We wanted to develop something where we got both the providers and the patients away from feeling super overwhelmed by this, and to say, there's a lot of comorbidities you have, but if you start to identify those things, and those might be depression, they might be sleep apnea, they might be smoking, any number of things that can be exacerbate this, and you do anything and those aren't the focus of this, but because those were co-writing factors, we wanted to demonstrate that if you address any of these factors, it starts to move this in the opposite direction. The domains in green are really what we're trying to affect in this intervention, and what we were trying to prevent is people sort of moving back and forth between the passive treatments that are below in that brown piece and really searching for causes of if I just find the magic bullet. So I want to talk about when we've been rolling this out, what are some of the challenges? And I think when we talk about measurement-based care and that kind of thing are, okay, 5 minutes, things that you really have to grapple with. When we started this trial, we had thought we were home free because these were patients that were on chronic opioid treatment, and by virtue of being having opioid therapy plans, they were supposedly getting at every visit the BPI. When we really looked at it in practice, most of these patients were getting that about once a year. The other thing that you'll see here on the lower left is just an indication that even if you've got an electronic health record that you can use robustly, you have to have something that sits on top of that really allows you or allows the PCP to manage this and to be able to identify when people need they need assessing. This is what our co-investigator in Georgia did to try to set up in the system there that didn't have really a protocol at all for pain assessment. It shows just by virtue of looking at how complicated that is that there's just a lot of different steps in establishing the care. So we moved the entire Kaiser system from the 12-item BPI down to the 4-item PEGs. They were delighted to do that because the primary care environment, 4 items is so much easier than 12. And they also said, well, this really focused them on functioning because there was 1 pain intensity item and 3 that really had to do with functioning. That even with all that work, it really wasn't happening in the clinical workflow. So what we ended up doing is enhancing this with really an automated kind of system. So we use what's called kp.org, which is the Kaiser form of the personal health record. We push out quarterly the PEG by email, a secure email. About 20% of the people respond in that way. If they don't respond in that way, then we push out through the IVR system an automated call, and that again is through a customized thing within Kaiser that's KP Messaging Center. And only if they don't do that do they have to be called by a live medical assistant type person. And so this is a system that that now our Northwest region is really looking at adapting or adopting for PROs more generally. And I think it's the kind of thing we need to be able to do if we're really going to make some traction here. I'm going to, in the service of time, go past that. And, I think that the point here is we also do an intake for our intervention folks that uses a lot of these legacy tools and gets it into an actionable form. But we've done that in an untethered way and then push it back into Epic so that that we can really, Epic just doesn't really have the tools. And I'm going to go past the process stuff so I can talk about some of the barriers. Suffice it to say that there's a lot of process to do around this, and these are all the people that we have to touch in our systems in order to really be sure people are on board. There's a lot of leadership change, so we are constantly in the field really keeping people apprised of what we're doing and on board. So the underbelly of this urgent clinical question, and I think that Aaron really demonstrated this, is that there's a lot of change happening. So this demonstrates across these 3 regions all the changes in leadership that have happened over the time we've been in the field. These are the changes in opioid prescribing practices. These are other initiatives that are taking place in pain that are part of our, quote, usual care. These are other initiatives that involve behavioral health that have been rolling out in the midst of this. These are large things like Kaiser had a mass retirement at the end of this year, which shifts a lot of the staffing, and then the kind of national guidelines that you all know about. So I think when you're doing this work, just to know you've got that kind of a background. And then the implications of some of these things, I need to wrap up. So there's a piece of this I'll talk about up here if I can, is that if you can compare 2 active treatments, I think that that's helpful because you can sometimes, with some of the more local things, keep people from doing these kinds of simultaneous, implementations. Involving, others have talked about this, but I think involving the folks in the clinics so that they're really refining it in a way that works there. Plan for constant surveillance and measurement of usual care, and that you really have to budget for all these things. So I'll go ahead and stop there and answer questions when we get together as a group.